Assalamu alaikum class. I hope you guys are good. So today I'm going to discuss with you the thyroid function test. It's one of the labs that we have to do because there is no practical performance and just a demonstration, so we thought to incorporate it in your slate schedule or in your timetable now that we are not going to the college, and we will resume with the other labs once the college opens. The two labs which are from this endocrine module are um, oral glucose tolerance test and estimation of blood glucose levels by glucometer. So the learning objectives here, as I walk you through the presentation, and by the end of the presentation you would be able to learn about the introduction to thyroid gland, the synthesis of thyroid hormones, regulation of the synthesis of thyroid hormones, the function of thyroid hormones, the commonly occurring conditions associated with the thyroid, hypothyroidism, hyperthyroidism, thyroid goiter enlargement of the thyroid gland, thyroid function tests and their interpretation. So what is the thyroid gland? A thyroid gland, it's an endocrine gland located anteriorly in the neck between C5 and T1 vertebrae, and it's divided into two lobes which are joined by an isthmus forming a butterfly shape. It lies behind the sternohyoid and sternothyroid muscles, literally wrapping around the cricoid cartilage and superior tracheal rings, and it's inferior to the thyroid cartilage of the larynx. So this is the like I've touched upon the anatomy briefly. As you can see over here, these are the two lobes which are joined by the isthmus, and they form a perfect butterfly shape. Now, the tissue of the thyroid gland is composed mostly of the thyroid follicles, and those follicles are made up of a central cavity which is filled with a sticky fluid called the colloid. So surrounded by a wall of epithelial follicle cells, the colloid is the center of thyroid hormone production, and their production is dependent on iodine and the precursor thyroglobulin. So the thyroid hormones are formed from iodine and thyroglobulin. Once they are formed, the triiodothyronine, which is T3, and the tetraiodothyronine, these are the two hormones. The T4, also called as thyroxine, the T3 and T4. The T3 is also called as T3 is triiodothyronine and T4 is tetraiodothyronine, also known as thyroxine, and they are produced in the colloid, and once they are produced, they diffuse across the follicular membrane to enter the bloodstream. Now, as you can see over here, this is the synthesis of thyroid hormones. So initially, like I told you, that thyroglobulin is a precursor. We need iodine and thyroglobulin to synthesize the T3 T4. So thyroglobulin is a precursor of T3 T4, and it's synthesized in the basal portion of the cells, from where it moves to the lumen, and it's stored in extracellular colloid. So it consists of amino acid residues which act as a prohormone. So thyroglobulin consists of amino acid residues, and they act as a prohormone. So this is a very good diagrammatic representation of the synthesis of thyroid hormones. As you can see, in the first step, there is the thyroglobulin is synthesized and is discharged into the follicle lumen. Okay, as you can see over here, what happens next is there is iodine uptake. So there is iodide uptake. So there is trapping of the iodine. The iodine is taken via a carrier system, the iodine pump or sodium iodide support carrier system, and it's transported from follicular cells into the follicular cavity once it has oxidized. So it's uptaken, and then it's from the blood, and then it's oxidized into active or iodine, and once it's oxidized, it's taken into the follicular lumen. Here the iodine enters the follicular lumen and it's attached to tyrosine in colloid, and it's this iodine is transported from the follicular cells into the follicular cavity, like I said, or the follicular lumen. And iodine combines with tyrosine and thyroglobulin. So this process is called as iodination. Okay, so when the iodine combines with tyrosine, you call it iodination, and it's accelerated by an enzyme, iodinase enzyme, and it's secreted by the enzyme is secreted by the follicular cells. So then what happens is tyrosine is iodized in monoiodotyrosine, and diiodotyrosine forms. And then the iodinized tyrosines are linked together to form the T3 and T4. The process is also known as coupling. The coupling occurs when two diiodotyrosine residues combine, they form the T4 triiodothyronine. And when diiodotyrosine combines with monoiodotyrosine, it forms T3 triiodothyronine. So 2-DIT form T4, DIT and MIT form T3. Hypothalamic pituitary thyroid axis. What is this axis? Basically, it's very important for you to understand this, because it's going to impact your understanding of the thyroid function tests. So the release of T3 and T4 from the thyroid gland is regulated by the thyroid stimulating hormone, as we know, and the thyroid stimulating hormone is released from the pituitary. So what's going to happen is thyrotropin releasing hormone, which is secreted from the hypothalamus, it's going to trigger the secretion of thyroid stimulating hormone from the anterior pituitary gland. And this thyroid stimulating hormone is going to stimulate the thyroid gland to secrete T3 and T4. So the level of thyrotropin releasing hormone, thyroid stimulating hormone, T3 and T4 are regulated by a negative feedback system, in which increasing levels of T3 T4 decrease the production and secretion of TSH and vice versa. As you can see here in this picture, if there is a low concentration of T3 and T4 in blood, it is going to cause the hypothalamus to release thyrotropin releasing hormone. It's going to sense the decreased T3 T4 in blood, and it's going to release, the hypothalamus is going to release a thyrotropin releasing hormone, which is going to act on the anterior pituitary to release the thyroid stimulating hormone. This thyroid stimulating hormone is going to act on the thyroid follicular cells, and they're going to produce T3 T4. They're going to release it into the blood, and where the effects are mediated. And what are the effects of T3 T4? They basically increase the basal metabolic rate, the BMR, and the body temperature. And when the circulating levels of T3 T4 is high, there is a negative feedback. The negative feedback works by inhibiting the release of release of thyrotropin releasing hormone and thyroid stimulating hormone. So they won't be released, and they won't exert their effects on the thyroid to produce more T3 T4. So this is the uh, hypothalamic pituitary thyroid axis. Now, what are the metabolic functions of thyroid hormone? The carbohydrate metabolism. It increases the glucose absorption from the GI, increases blood sugar levels, causes hyperglycemia and glycosuria, so it's a hyperglycemic hormone. And it increases glucose utilization and decreases glucose tolerance, which is, and this function is antagonistic to the insulin. It increases hepatic glycogenolysis since it enhances glucose 6-phosphatase activity. It increases catecholamine sensitivity, stimulates glycolysis, and increases hepatic gluconeogenesis. It favors protein synthesis and degradation, and increases lipolysis, mobilizes free fatty acids. Calorigenic action. It increases oxygen consumption in all metabolically active tissues, increases heat production and basal metabolic rate. Thyroxine is also necessary for hepatic conversion of carotene to vitamin A. So what are the now we are going to discuss the important conditions associated with the thyroid hormones. The hypothyroidism. Underactivity of the thyroid is usually the underactivity of thyroid, which is usually primary, caused by disease of the thyroid, but it could be secondary. So there is a primary cause and a secondary cause of hypothyroidism. Primary is because of the disease of the thyroid gland itself, and secondary is due to the hypothalamic pituitary disease, which is going to cause reduced TSH, thyroid stimulating hormone production, and the TSH drive. So these are the commonest causes of hypothyroidism. Commonest causes are iodine deficiency, and iodine deficiency in children also causes a condition called creatinism. In those areas which have sufficient iodine, the commonest cause is autoimmune Hashimoto's thyroiditis. Hypothalamic pituitary axis is also another cause. It's a cause of secondary hypothyroidism, congenital agenesis, ectopic thyroid enlargement, hormone synthesis. During hormone synthesis, there could be some enzyme defect. Antithyroid drugs affect the hormone synthesis, iodine deficiency. Then we have like autoimmune thyroiditis, post-infective thyroiditis, iatrogenic, drug-induced, lithium amide interferon antithyroid drugs affect the thyroid production. Post-thyroidectomy, we have reduced levels of T3, T4, radioactive iodine, radiotherapy to the neck, infiltration from tumors, peripheral resistance to the thyroid hormone. What are the clinical features of hypothyroidism? So you see a patient who has slurred speech. He is kind of not exactly slurred speech. He's going to be apathetic with and slow and lethargic, with dry hair, thick skin, deep voice, and weight gain. Cold intolerance. Intolerance is when the patient feels cold even during the hot weather. Patient complains of a patient will be having bradycardia and constipation. So these are the bradycardia, weight gain, cold intolerance, constipation. These are the classic symptoms, signs and symptoms. Milder symptoms include non-specific tiredness. They'll be slow and sluggish, but milder symptoms are hard to distinguish from other causes because not every patient with hypothyroidism presents the exact clinical picture. Many cases are detected on biochemical screening. Investigation of primary hypothyroidism, we perform the TFTs, thyroid function test. Serum TSH is the investigation of choice. A high TSH confirms primary hypothyroidism. Low free T4 levels confirm the hypothyroid state. It's essential to exclude TSH deficiency if clinical hypothyroidism is strongly suspected and TSH is normal or low. So, and if it, as we proceed, we are going to I'm going to share with you how the primary and secondary hypothyroidism affect the TSH. So, along with in patients with hypothyroidism, they could be having anemia, which is usually normochromic and normocytic in type, but maybe macrocytic. Sometimes this is due to associated pernicious anemia or microcytic in women because they have menorrhagia or undiagnosed celiac disease. So menorrhagia is one of the symptoms in the females. Increased serum aspartate transferase levels from muscle or liver damage, increased CK levels associated with myopathy, hypercholesterolemia. So the patients with hypothyroidism do present with hypercholesterolemia. Hyponatremia due to increase in ADH and impaired free water clearance. Now, hyperthyroidism. Hyperthyroidism is when there is thyroid overactivity or thyrotoxicosis, and it's very common, affects perhaps 2 to 5% of females at some time and in their lives, and have a sex ratio of 5:1. It most often occurs between the ages of 20 to 40 years. Causes of hyperthyroidism are autoimmune. The most common cause is Graves' disease, thyroiditis, decurvens thyroiditis, which is post-infective, postpartum thyroiditis, toxic thyroid adenoma, toxic multinodular goiter, drugs, amiodarone, iodine antivirals used for hepatitis, HIV, thyroxine. If a patient is taking thyroxine without any condition, HCG mediated, because human chorionic gonadotropin hormone is structurally similar to the thyroid stimulating hormone. During the first trimester of pregnancy, especially in hyperemesis gravidarum, HCG secreting tumors including testicular carcinoma, TSH secreting pituitary adenoma. Clinical features are spleen symptomology, and signs vary with age with the underlying etiology. There are various eye signs like lid lag and stare, where you find the patient's eyes are very protruded, and it's called exophthalmos, and it occurs in Graves' disease. Graves' dermopathy is rare and can occur on the extensor surfaces. Pretibial myxedema is common, and it's the infiltration of skin on the shin. Thyroid acropathy is very rare, and it consists of clubbing, swollen fingers, periosteal newborn formation. Now, goiter. What is goiter? The thyroid enlargement is called goiter. So there could be enlargement could be of three types: diffused, multinodular, and solitary. So you can have a patient with a diffuse thyroid swelling. You can have a patient or diffuse goiter, and usually it's in the case of it's from the hypothyroidism, from the underactive thyroid, the hypofunctioning thyroid. Then you have the multinodular goiter from and commonly it's seen in patient with a overactive thyroid, and you have a solitary nodule. It could be toxic or non-toxic. So most commonly a goiter is noticed as a cosmetic defect by the patient or by friends or relatives. Majority are painless, but pain or discomfort can occur. Large goiters can produce dysphagia, difficulty in swallowing, difficulty in breathing, dyspnea, implying esophageal or tracheal compression. Causes are physiological: pregnancy, puberty, autoimmune. In Graves' disease, you can see a patient with goiter, Hashimoto's, thyroiditis, multinodular single nodule, inflammatory decurvence, thyroiditis, tumors, thyroid cancers present with swellings, lymphoma, hormone synthesis failure, iodine deficiency, and dysharmonogenesis, infiltration with in case of sarcoidosis, tuberculosis, certain goitrogens, drugs including amiodarone and lithium. Now let's move to the thyroid function tests. There are several other tests that other lab investigations that we perform, but these are the mainstay. And the collective term for the blood tests used to check the thyroid function, we call them collectively as thyroid function tests. They are requested in patients who are thought to have hypothyroidism, hyperthyroidism, and to monitor the effectiveness of thyroid suppression or hormone replacement therapy. They're also requested in conditions linked to thyroid disease such as atrial fibrillation and anxiety disorders. In hyperthyroidism, patients can present with atrial fibrillation. And anxiety disorders, patient with hyperthyroidism, you are going to see them. They have tremors and sweaty palms. So and you differentiate the patient with hyperthyroid from the anxiety state by looking for the feeling that their hands. The patient with the hyperthyroid patient is going to have warm hands with tremors, and the hypothyroid and the patient with anxiety is going to have cold clammy hands. Now the thyroid function test panel includes thyroid stimulating hormone or thyrotropin, thyroxine T4, triiodothyronine T3, which is the active form, and it's a more potent form. Many cells convert T4 to T3 through the removal of an iodine. The normal concentrations of free T3 are 80 to 220 nanograms per deciliter, free T4 0.8 to 2.4 nanograms per deciliter, total thyroxine 5 to 12 micrograms per deciliter, and TSH less than 4 milli-international units per liter. So how do you interpret? In case of hyperthyroidism, the TSH is low free T4, T3 are high. And if you remember the hypothalamic pituitary thyroid axis, if there are high levels of T3, T4, it's going to suppress the thyrotropin releasing hormone and the TSH, so they will be automatically low. The TSHs will be low to stop the further production of these hormones. The thyroid hyperthyroidism, thyroid T3 toxicosis is isolated T3 toxicosis where there are high T3 levels but normal T4 levels, and the TSH is low. Primary hypothyroidism. In primary hypothyroidism, just from the I have previously discussed with you, the TSH is high because there is underfunctioning thyroid, hypofunctioning thyroid. So the serum free T4 and T3 are low. In hypothyroidism secondary to pituitary disease, there will be normal TSH with low T3, T4. So here, this is how you differentiate between primary and secondary hypothyroidism. This is the picture that I got from Davidson Book of Medicine, and here you can see that like I have previously discussed with you in the previous slide. It's the same. You can see the in primary thyrotoxicosis with raised T3, T4, you have undetectable levels of TSH. Primary T3 toxicosis, where there is just raised T3 with normal T4 and undetected TSH. With subclinical thyrotoxicosis, there are going to be normal T3, T4 with undetectable TSH. In non-thyroidal illness or amiodarone therapy, you will observe low or normal T3, raised T4 with low or undetectable TSH. In secondary hypothyroidism, there are going to be low T3, T4 and undetectable TSH. And this is the secondary in secondary hypothyroidism. Wait a second. Low T3, T4 with normal or TSH. So this secondary hypothyroidism is for this transient thyroiditis in evolution. And here there is a defect in the hypothalamic pituitary hypothyroid index, hypothalamic pituitary thyroid index. Primary hypothyroidism, there are low T3, T4 with my elevated TSH in the range of 5 to 20 milliunits per liter. In primary hypothyroidism, there are low levels. It could either be mildly elevated or elevated. And in subclinical hypothyroidism, T3, T4 are normal and TSH could be mildly elevated. in a patient with non-compliance with T4 replacement, the after a loading dose, T3 T4 could be raised with an elevated TSH. So this was all about the thyroid function test. Thank you.